Hello, this is Fernando Gomez Sancha, and this is another real-life thulium case using the Lisa Laser pulsed thulium, and this is the second video on a series of videos that I hope I can be uploading. This is a case, a relatively strange case where a patient was prepared for me to operate. I didn't see the patient before the operation, but I went to do a waiting list of patients, and this patient was programmed for surgery because of obstructive voiding. He had had a TURP before, and as this was probably quite a good cavitation surgery, but there was some apical tissue, and probably this was the cause for his voiding problems. So in the redo cases, many times when you come in, you see a reasonably big fossa, and that can be sometimes misleading. I always remember the work of this French professor Bertrand Lukács, who used to do voiding cystoscopy as a test. So he would use I think it was a bronchoscope, a very low caliber optical instrument, introduced it in the urethra of patients and asked them to void. So he recorded the voiding, what was happening inside the prostatic fossa when patients were voiding, and he could see very impressive information. For example, how the middle lobe folds and gets into the prostatic urethra, blocking it completely. Sometimes, I really recommend you to look it up. There must be some videos on the internet available. I'll see if I can find them and link them below. But what I'm trying to say is that often the endoscopic view doesn't represent what happens when the patient voids. So you can find cases like this. And also I think this video is interesting because it shows how it's always worth to look for the plane, and when you do a redo treatment, you have to be aggressive removing the tissue, because this represents the second operation of the patient, and you wish it could be the last. And also because when you see this fossa, you think, wow, it was really radical. There was no tissue left, and you will see how we are able to extract more tissue, and there is more adenoma left than one would think. Also, I think this video highlights how this laser, a thulium laser, has the advantage of excellent cutting properties. So when you're dealing with fibrous tissue like this, it is a nice property. You know that this laser is slightly different from a holmium in the sense that probably the dissection effect is a little bit less marked, but when you have experience, and when you learn how to navigate these dissection lines, I think when you set the depth of the dissection with your posterior line, and then you take it to the side, like we are doing now, and you follow the line, I think you get a pretty good idea of where the capsular level is. Sometimes there's a good plane that you can see, and you're very happy developing this plane because you're absolutely certain this is the proper plane, because you see the nice interface between adenoma and capsule. But some other times there's no good plane, and then you have to rely on other factors like the congruence of the line that you're following, the quality of the tissue you are leaving in the side of the adenoma and in the side of the capsule. Adenomatous tissue tends to be more yellow, capsule tends to be more white. So you have to learn to recognize the plane, not only by watching this beautiful glistening surface that we like to see, but also by looking at other factors like consistency of the plane, smoothness, fibers, visible fibers on the surface, color, etc. I think if you want to do enucleation and you rely on seeing this beautiful capsule, you're going to be frustrated because often it's very difficult to see. And also with all these lasers, sometimes the energy is going to change the aspect of the capsule. But after doing many cases and after doing a lot of intraoperative transrectal ultrasound and postoperative transrectal ultrasound, I can tell you that I can recognize that the depth is correct more and more without having to see this glistening plane. So here you see I'm progressing. I also trust the lines. With this en bloc technique you can more or less anticipate, or your brain helps you understand how the anatomy looks like, and if you follow these lines, it can happen. You can sometimes cut through the adenoma and leave a small piece of adenoma, but most of the times I think it's going to be very evident. You see that we are following more or less the same steps. This is a 12 o'clock fibers. When I do these movements, probably I'm explaining, while I'm doing the operation to someone who is watching. But here you can see how I developed. I first marked the white line right at the edge of the sphincter. Often with TURP, I think there's apical tissue left. There is this traditional teaching that you shouldn't resect below the veru, but then often there is a lot of adenoma at the apex, which can be obstructive, even when the fossa looks so beautiful. That's why it would be very interesting to have a voiding cystoscopy of this guy to check what was obstructing his voiding. But also I think this video, reflects the beauty of the en bloc approach for redo cases. Sometimes when you do redo and there's much more tissue left, you cannot even enter the bladder because it's very difficult, because the synechia. Well, here you see what I mean. That looks like a good plane. So what I was saying is that when you do a redo case, it's very nice to use the en bloc technique, because you can deal with the problem once and for all very elegantly. You see the excellent visibility that this laser provides, but also the en bloc technique provides excellent visibility, because we are irrigating a very small space. And as I said, if you have difficulty entering the bladder at the beginning, you don't need to force your entry. You can start right away at the apex and progressively dissect, and you will see the bladder later when you enter the bladder anteriorly. Now you can see the circumferential line. It's a congruent line, and probably we are now at the equator of the operation, and now it's important to be vigilant and to check where you are cutting, because often the angles of the plane start to change. For example, here you see we have to start pointing downwards, because the anterior plane is going up at the beginning and then it's going down. And often when we are here in the procedure, we have to start firing closer to the adenoma. Here, this is the entry already into the bladder, I think. You naturally are going to go there. Here you can see one of the nice aspects of this laser is that the cutting is very good. It's like cutting through butter. You know, the bladder neck fibers, especially after treatment, they could be very, very fibrous. So it's nice to have a cutting tool that cuts really well without causing disruption, which is what holmium would typically do. This was a movement I did to explain that if you are afraid to enter the bladder anteriorly, you can always go inside the prostatic urethra and make a 12 o'clock cut to localize the entry point. But in this case, it was very evident. And here you see how often the endoscopic appearance of a fossa can be very misleading. We cannot always predict if a patient is obstructed or not by the look of the fossa. That's a utriculus. You can see that I like to open the utriculus so that it doesn't remain as a closed cavity where urine could pool and cause postoperative infections. So if I see a big utriculum, I like to marsupialize it into the fossa so that there is no chance for retention of urine and stone formation and the like. So here you can see how this laser is cutting through this fibrous tissue. Yeah? There's no good plane, but I am developing the plane, as I said, trying to constantly examine the quality of the tissue that we are leaving in the capsule, and also controlling my aiming. You know, I want to fire close to the adenoma so that most of the energy goes to the adenoma, not to the capsule, but still helps cutting the attachment fibers. The fibers are touching the adenoma to the capsule, to the surgical capsule. Most people always ask me what settings you use, and I think settings are important, but there are three factors that also determine the effect on the tissue. Of course, one of the factors is working distance. You can fire closer to the tissue and get a much more disruptive effect, much more cutting effect. You can separate the fiber progressively to the point where there's almost no cutting and there's only coagulation. If you separate it more, there will be nothing. So working distance is factor number one. Operator dependent factor number one. The second factor is going to be the speed of movement of the fiber. So if you're moving very slowly, the effect is going to be different as if you move fast, or, you know, in between, not so fast, not so slow. So the second factor, operator dependent factor, is going to be the movement of the fiber. And then there's a third factor, and that is the aiming. Where do you aim in relation to the line of dissection? So if you aim closer to the capsule than you might risk perforating the capsule. If you fire against the line, it's okay, it's perfect for the initial half of the procedure, and then you could fire closer to the adenoma, so a little bit inside of the line, if I make myself clear with that, like I'm doing now. You see, when you have to work these angles that are changing, you have to keep your fiber closer to the adenoma so that the disruption cuts the fibers, but it doesn't penetrate on the capsule. And these are the three key factors of surgeon influence on tissue effect of the laser. Not just the settings, but how far you work in relation to the tissue, how fast you move, and where you aim your laser. These are the three important factors, because you have to master you have to be able to predict how the energy is going to interact with tissue in different moments of the operation. Here you see I want to detach the lower part of the adenoma in a very fibrous prostate, because this tissue was resected, and we're just treating this, developing this plane after the inflammatory process that that took place after TURP. But so I was very satisfied with this laser for such a case because of the excellent cutting properties, and as you can see, the coagulation is really impressive. The first pass coagulation is very good, and maybe there is a less disruption effect, less dissection effect than holmium, but as you see, these new lasers are changing a lot endoscopic enucleation because the quality of hemostasis is really good, and I think that's going to facilitate learning for the majority of people. So here you can see that we are going to remove like a donut of tissue, hoping to improve the situation of the patient. Also, as you can see, Bloc is very fast because the majority of the time the laser is activated, and as I usually say, every minute you have to do things that make the situation better, so the procedure advances. See how the targeting is very careful. I'm targeting near the adenoma so that there's no penetration in the capsule, and if you master these 3 factors and adapt, the effect of the energy into the tissue to what you want to achieve at different moments in the operation, then you can master. If I fire against the line, you see, I will cause a perforation. But if I fire inside of the line, closer to the adenoma, I will get this effect that cuts the fiber very gently, without possibility for penetrating too much into the capsule. Of course, as I do the dissection, I have to correct the aiming again to get even closer and closer to the adenoma until we can flip it. It's impressive to see how much tissue was there despite the look of a very nice fossa after TURP. So you cannot believe sometimes how much more tissue there is to remove if you want to be radical or anatomic. And here you see this is the final moments trying to get to the bladder neck. Sometimes when I'm going to do that, I switch the fiber to 6 o'clock, but sometimes I don't. Depends on how accessible this is. I know that the UOs are quite far away because we saw them at the beginning of the procedure, so I was quite confident to continue dissecting. And here it is. You see, I switched to 6 o'clock to have a slightly better angle. I was wondering what that was, but the UO is far away. Yeah, okay. So it's always good to check, and this is probably the most fibrous part of the tissue, and look how it cuts. It's like butter, very nice, like butter with a knife. So that's the end of the enucleation. You can see the perfect sphincter preservation, and you can see excellent hemostasis in the fossa, radicality of the procedure. So, well, an interesting case, and I think providing important points for learning. That endoscopy doesn't predict obstruction, and that apical tissue sometimes can behave as obstructive tissue, and also how subtleties or subtle changes in how lasers work are sometimes quite useful, like the excellent cutting properties of this laser. I have no more clinical information about this patient because he was going to be followed up by other colleagues. But I'm sure that the obstruction is gone. Sometimes this fibrous tissue is difficult to morcellate. And here you can see the camera was getting a little bit wet, but visibility was good enough to continue, and of course it's not a big adenoma, so I think I decided to continue with the morcellation. That is almost finished now, I think. So I hope you enjoyed this case. It's a relatively short video, but I think a very nice case. Thank you very much.